So guys, welcome to part 2 of what to do with a diabetic patient. So we said that on the previous video, we said that there are things that need to be done for a diabetic patient at every visit. There are things that needs to be done 3 months, every 3 months, or every 6 months. There are things that needs to be done annually. And we said that things that needs to be done at every visit for a diabetic patient is the BP, whether they are hypertensive or not, because we said that hypertension and diabetes are very good friends. So BP, and we said that diabetes and obesity are very good friends. So you want the weight and the BMI. Yes, you want to check the blood sugar. The blood sugar that you'll be checking at the clinic, it doesn't really tell you about how controlled the patient is, because the patient can be controlled for the past weeks, but then when they came to you, they just ate something that elevated their blood sugar. So it's not a very good marker to check if the patient is controlled or not. And you can't say when a patient comes to you, they've got a blood sugar of 30 or of 25 or 20, you say they are uncontrolled based on their instant blood sugar. So it's not a good marker to check for control. A good marker to check for control is HbA1c and the development of complications. This one, so the reason why you do this is just to see if you might need to lower it before they go, because someone can come in with a blood sugar of 20 and then they're talking and walking and then they just came to the clinic, and you cannot discharge them with a blood sugar of 20. You need to do something about it. And oral medication struggles to drop a blood sugar that is above 15. So it just becomes a snowball effect, because they will go home with a blood sugar of 15 and then they continue to eat, and every time they eat, the blood sugar goes up, because the orals, they struggle to lower a blood sugar of more than 15. It's even worse with metformin. Metformin struggles to lower a blood sugar that is already high. It's good to control a blood sugar that is already low, but not a blood sugar that is high. So, and we said that you want at every visit to do a foot inspection. Not really a complete foot examination, but just the inspection at every visit. Yes, you want to counsel them about smoking cessation at every visit. And then now, like I explained, that you want to check their HbA1c every 3 months if they've been having problems with medication, or if they've just started a new medication, or if they've just started their medication, or if they had problems, or you're just introducing or they've got adhering problems. So you can do it, you can do the HbA1c every 3 months. But for someone who's perfectly controlled and you have managed to reach the targets, the HbA1c targets, you can do it every 6 months. So if you have not managed to reach the targets, HbA1c targets, then you need to do it every 3 months. Okay, so what do you have to do annually? Annually, you need to do fasting lipid profile, because we said dyslipidemia is also a good friend of I hope you guys know what they call metabolic syndrome. Basically, metabolic syndrome syndrome is diabetes central. Apparently, the most dangerous obesity is central obesity, which is obesity around our abdomen, and hypertension. So these three are called metabolic syndrome. So it's important to actively look out for them and not be caught by surprise. So we say that annually you need to do fasting lipids or lipid profile, and also you need to do a protein creat ratio, protein creatinine ratio. By the time, so basically a protein creatinine ratio is just checking how much protein are you losing in the urine. Are you leaking some albumin in the urine? Because if you are leaking a lot of albumin in the urine, then you might have developed a nephropathy. But obviously you need to check for other things in the history examination if the patient doesn't have any other conditions that causes a lot of proteinuria. But in the absence of other causes like nephrotic syndrome, and the patient is diabetic, the most likely cause is the nephropathy. So you do a protein creatinine ratio, take the urine and send to the lab. If the protein is more than 300 milligrams per gram of creatinine, this is called a dipstick showing proteinuria or overt proteinuria. So by the time you've got a positive dipstick for proteins in the urine, it means that already you are already excreting more than 300 milligrams of protein per gram of creatinine in the urine. But when it's still less than 300, then your dipstick will remain negative. So basically what this tells us is that by the time you've got a positive proteinuria via a dipstick, the patient is already in trouble in terms of their nephropathy. So it means that we shouldn't get excited when a dipstick is normal of a diabetic patient. We should still do the protein creatinine ratio. The nice thing about it is that you do it only once a year. And that's your protein creatinine ratio. This one is checking for nephropathy. With this one, we're checking for dyslipidemia, because we said dyslipidemia and diabetes are friends. So another thing that we need to do every year is that comprehensive foot exam that we spoke about. Comprehensive foot exam. Here we are trying to check for the neuropathy, because we said that the complications of diabetes, the long-term complications of diabetes, yes, we've got the short-term complications, which is like DKA, like the diabetic emergencies. We spoke about those, so we did mention them. But here we said that long-term complications of diabetes are microvascular and microvascular. So now, as long as we know that it's for microvascular, we've got this. For macrovascular, we've got this. So for instance, we said that for microvascular, one of them is a neuropathy. So how do you look for it on a patient? Comprehensive foot exam, and also the history needle like pricking pains, numbness on the foot, not being able to feel sensation, things like that. But you need to examine for the foot, the pulses, all those things. And then we said that one of the microvascular complications is nephropathy. Now, your protein creatinine ratio test will help us to diagnose that. Yeah, so we do that. Another thing that also becomes very important is the for the eyes. Now, for the retinopathy, we need to send this patient for a, or if you've got someone who can do it, dilated eye exam, which means that there are people who can do this, especially who are senior doctors. So basically, there you give a patient something that's going to dilate their eyes so that you can be able to see nicely what is happening with the retina. So they should do that every year, dilated eye examination. One other thing that is also important is yearly dental examination. So those are the things that should be done every year for our patients. So the other thing that becomes important is, now there are things that needs to be done every 2 to 4 years. Every 2 to 4 years. One of those things is a complete nutritional history, which means we can send this patient to a dietitian, basically. Dietitian. Diabetes is a condition of, it's 80% about what you eat there. What controls your blood sugar is 80% about what you eat. So dietitians are very important to be involved in these kind of situations. And also physical activity, like this patient needs to be encouraged to exercise, and also like really go down in terms of explaining the importance of physical activity, and also to look into their pattern of exercise or of living, if they've got any form of exercise and all of those things. So basically, friends, what we are gathering here is that from this is that, before we move on to the next part, is that every visit we should be doing these things for a diabetic patient. We cannot be doing HbA1c every time we see the patient, because we know that HbA1c, it only changes every 3 months of a patient, because that's how long red cells stay in the circulation. So there is no reason why we should be doing HbA1c every time. And also, one other thing is, lipid profile is done every year, should be done every year for a patient who doesn't have, because this is like a screening kind of a thing, checking them, because it needs to be done every year. So with because we anticipate that this patient might develop some form of dyslipidemia. Remember, dyslipidemia, we are going to talk about it. It's not only high cholesterol or hypercholesterolemia. You can have high triglyceride as well, or you can have mixed lipid disorders. Like you can have hypercholesterolemia with hypertriglyceridemia, and things like that. And also, someone who's hypertensive, the minute you are hypertensive and you develop hypercholesterolemia, high blood pressure becomes hard to control up until the cholesteremia is treated, because high cholesterol causes some kind of occlusion in the arteries, and if you occlude arteries, you develop a high peripheral resistance. And we know that once you increase peripheral resistance, blood pressure goes up. So yeah, so guys, so I hope now we will know what to do. So we say these ones, we do it at every visit: the BP, the weight, the BMI, the blood sugar, foot inspection. Cancel them about smoking. If they are still smoking, encourage them to stop. And then we do lipid profile every year. We do our protein creatinine ratio every year. You can do a dipstick at every visit. It's not gonna cost much at every visit. It's okay. You can do a dipstick every visit. Let's put a dipstick here as well. Doesn't cost, doesn't take time. So, and then comprehensive foot exam every year, dilated eye exam every year, dental examination, send this patient to a dentist every year, and then that's it. So guys, one other thing that I want us to talk about now is the issue of so we do have this we do have now our vascular complications, right, that we have spoken about. We've spoken about our vascular complications. So now I'm not going to be specific. Vascular complications. So I'm not going to be specific, microvascular or doesn't really make a difference. So there is primary prevention of this, and then there's secondary prevention. So when it comes to prevention of these, there's primary and then there's secondary. Secondary prevention, as you know, is someone who has had some form of a complication. Now we want to make sure that they don't develop another, or they don't get the same complication again. That's a secondary complication. So it's someone who has had maybe CVA. They've had, in this context, they've had TIA, maybe they've had an MI, or maybe just say acute coronary syndrome, or they've had they already have peripheral vascular disease, or they have claudication and other vascular complications. So that's a secondary. So what you want, these patients, they have to be on aspirin, and that aspirin should be between 75 milligrams to about 162 milligrams per day. They have to. In the event that a patient cannot take aspirin, maybe they've got allergy. Allergy is the only thing, so they can be on clopidogrel. So, but most patients are on aspirin. Many of them are on 150 milligrams. So this is what becomes very important. You have a patient who's got diabetes, and then they've had a vascular event, because these are vascular events, so they need to be on secondary prophylaxis of aspirin. There are some guidelines, but I'm not sure if this is done in South Africa, that when you've had an acute coronary syndrome, you should be on 2 antiplatelets for at least a year. So which means a patient who has had CVA, TIA, MI, who has a history of claudication, who has got nephropathy, who's got PVD, they should be on aspirin. Now let's talk about I've seen patients with who have got hypertension on aspirin. I don't think it should be the case. Remember, when this patient happens to bleed and then they are on aspirin, it's gonna be disaster. So the effect of aspirin on hypertensive patients, at this point, I'm not very sure why they should be on aspirin if they're not diabetic. and their cardiovascular risk is low. Okay, let's talk about primary prevention. Primary prevention is someone who's got the risk factors, but they have not had an event, vascular event. They've not had, but they have the risk, which is like in this case, for instance, in this case, it's diabetes. So whether you put them on aspirin or not depends on their cardiovascular risk. So what you can do here, you can use an app. There's an app, cardiovascular risk assessment. You can use that app. So it will tell you about the patient that you have. It will tell you their risk in the next 10 years, their cardiovascular risk in the next 10 years. So it's a 10-year risk, and then you check. So it's gonna tell you if it's more or less than 10%, but the cutoff is 10%. The cutoff is 10%. So which means that when you have got a patient who has diabetes, you take your app and then you puncture their information on the app, and it's gonna tell you if they let's say if their risk assessment comes as 7.5. It says that this patient has got 7.5% chances of developing any cardiovascular event in the next 10 years, which is very low. We don't have to do anything about it, but we worry when it's above 10. That's when we start to give the aspirin. So the things that you need to have to do the cardiovascular risk assessment, you need the age of the patient, you need the gender, you need ethnicity as well, and then you need your LDL, you need your HDL. So you must have your lipid profile there, LDL, HDL. You need your systolic BP. You need to know if they're being treated or not. It's a very simple calculator. Just look for it, guys. So there you just puncture your numbers. There, and it's gonna tell you what risk this patient has. If their risk is more than 10%, yes, put them on aspirin. But if it's less than 10%, it's not worth it. So yeah, that's it, guys. I don't know if I'm missing anything that I wanted to say, but I think that's it. So remember secondary prophylaxis, and remember primary prophylaxis, and remember the thing is when you have had, let me just explain this. When you have had an event, the cardiovascular risk assessment does not matter, because now you're already on this side, so you should have your aspirin. But if you have not had any cardiovascular event or any vascular event for that matter, then you should have your risk assessment being done before someone can decide. This tells us that not every diabetic patient should be on aspirin. Not every diabetic patient should be on aspirin. It depends on their cardiovascular risk assessment. So thank you so much, guys. Oh, okay. Before I leave this, almost forgot.